Hello. So my name's Jess Watson. I'm a GP, feeling slightly out of my comfort zone here, but it's great to be here today. When I'm not a GP, I'm a clinical lecturer and I'm involved in research into how GPs make a diagnosis and diagnostic testing. And so I've been asked to talk today about how GPs make sense of diagnostic tests. And what I want to try and cover briefly is a little bit about how we as GPs make a diagnosis, what are diagnostic tests, then the theory of interpreting diagnostic tests, so this is sort of thinking about Bayes' theorem in particular, and how that really works in clinical practice, in reality, where the gap lies between the theory and the practice, and perhaps think about how that could be improved. So how do GPs make a diagnosis? The aim of this slide is really to show you that there's a number of different strategies that we use at different stages, from the initiation through to refinement and through to defining the final diagnosis. And the tests are at the bottom there, are just one small part of that whole process of diagnosis. When I'm talking about tests, I'm talking about a wide range of things here. Just to be clear, this could be a blood test. Most people here will have had a blood test at some point. It could be urine tests, it could be more invasive tests, imaging, scans, or even endoscopies, things like that. And I think what's really important to get across to the general public and also to clinicians and to GPs is that tests don't actually determine if you have a disease or not. They don't even determine your chance of having a disease. What they actually do is they update your chance of having a disease, and I want to try and explain that and how we can implement that in practice and explain that to patients. And I think we had a talk earlier about how stories can help, so I'm going to tell a story. That's what I do as a GP, listen to patient stories, and I'm going to tell you about a patient, Mary, who comes to see me on a Monday morning with typical symptoms from a primary care perspective of some non-specific abdominal discomfort and some loose stools. So this is common presentation, and there's multiple different causes. She's been putting it down to a bit of stress at work, but I start to wonder whether it could be something else. In particular, could it be something like celiac disease? So often delayed diagnosis, often presents non-specifically, and there is a simple blood test that we can do. So before I tell you about Mary's test results, I just want to explain a little bit about how we calculate the accuracy of blood tests for celiac disease. And we do that by running diagnostic test accuracy studies where we take a population, all the population receive an index test, in this case our blood test, our simple blood test, and they also receive the best way of diagnosing, which is a duodenal biopsy, which is how we determine whether they do or don't have celiac disease. And we can then categorise them into these 4 groups in a 2-by-2 table. So very simple. I'm no mathematician. This is about as complicated as it gets for me. We have our people who are in the true positives. They've got a positive blood test result and they have got celiac disease on biopsy. We also have these false positives. These are patients who've got a positive blood test but don't actually have celiac. And we've got our false negatives. These are the people who have a negative celiac test result, but they actually do have celiac disease on biopsy. And with these 4 simple numbers, we can calculate everything. And in particular, what we calculate and what we've all heard lots about on the news and in More or Less and over the last few years, particularly in relation to COVID tests, is sensitivity and specificity. So our sensitivity is commonly misunderstood. It's the proportion of individuals with the condition who test positive. And the specificity, the proportion of individuals without the disease who test negative. So, what does this mean for Mary? Well, her blood test comes back and is positive. And we know from research and from studies that the accuracy, the sensitivity of this particular blood test is just around 90% and specificity slightly lower, high 80%, 87% or so. So what's the likelihood that she's got celiac disease? Well, of course, the problem here is that the common misconception is that the likelihood is going to be around 90%. But this is where the issue lies, and I'm sure that everyone here in the room recognises these formulas here and will recognise the problem is an issue of conditional probabilities. So sensitivity will tell us the proportion of the individuals with the condition who test positive, but what we want to know for Mary is what's her probability of having the disease given her positive test result. And of course this was looked at by Thomas Bayes, and here's Bayes' theorem. But the key thing is that to calculate this positive predictive value, or PPV, what we need is the pre-test probability. So how do we do that in clinical practice? How do GPs estimate this pre-test probability? Well, we probably don't think of it as estimating a mathematical formula like this, but it's the core teaching of medical school. Is we take a history, we examine the patient, we find out about symptoms, how strongly are they suggestive of celiac, is there a family history, has she got a past history of associated conditions, and there are tools as well to use. There's a great website here called Testing Wisely, and it's got some disease calculators where we can input these different things. And the estimate that comes up with for a patient like Mary with symptoms is that she's probably got around a 2% pre-test probability of having celiac disease. What I do with my students when I'm teaching this at medical school is we get them to think like this. Think of 1,000 people like Mary. And when we think like that, it's easy to see that if the pre-test probability is 2.1%, then 21 of those people will have celiac. And if we look at a sensitivity of 90%, around 19 of that 21 will test positive, will have true positives. But if we look at the other aspects of the tree there, we'll see that the 19 test positives, true positives, will also have 123 false positives. And so the actual positive predictive value for a patient like Mary is perhaps slightly surprisingly low. It's about 13% chance that she has got celiac given her positive test results. So when we teach this in medical school, we get people to work this out by hand. Do I do that in my clinical practice on a day-to-day basis? I'm afraid not. In this context of a 10-minute consultation, it's just too laborious. And there's lots of tools out there to try and help us implement this in clinical practice. Bayes normograms. I quite like these leaf plots here on the left there, and I think it's a useful tool for teaching, because what we do there is you start with the pre-test probability in the middle axis there, and we can visually see how much we need to adjust that up or down depending on the positive or the negative test results. So these are tools for really helping clinicians to hone their skills, but in real life clinical practice, I have to say, rarely used. So we've done some work, and I think COVID has really sort of shone a light on these issues, and I've been involved in trying to develop some tools to improve understanding and improve teaching around test accuracy, including sort of interactive infographics like this. So you can plug in different numbers, you can play around with it, see what happens if we increase the pre-test probability. And we've got our 2x2 tables, which sort of moves around in an interactive way to help us interpret our test results. But what happens in reality is a little bit more like this. I like to think of it as a Sherlock Holmes thing. It's about, we often, rather than using the slow thinking, we use our thinking fast, our kind of type 1 Kahneman thinking of mental shortcuts or heuristics. We use a tool, we can think of it like anchoring and adjusting. So you anchor on the pre-test probability before you do that test result, and then you adjust based on the test results. And it kind of looks, in my mind, a bit more like this. There's not numbers attached to it, but it's a spectrum. And we can think, when we first speak to Mary, she's in the sort of low risk, but when her test result comes back, that shifts the probability. And if she had a family history, or if she had 2 positive test results, then that probability shifts further still. And that's a little bit more about how it works in clinical practice. But I think there are sort of limitations to that. What does this mean for Mary, though? This is the really difficult question. How can we communicate this to her? So I think this is something that actually we do really struggle with, communicating the uncertainty. And when we look at guidelines, the answer to this question is simple. Yes, she should have a biopsy. But when we speak to patients, and I've done surveys with patients about how sure they'd like to be before starting a gluten-free diet. And the answers that they give vary wildly because, you know, people are different. It can be an invasive test. You have a long waiting time for the test. You have to continue eating gluten with ongoing symptoms while you're waiting for that test. So actually, I think we need to move towards sharing information with patients, using tools, using infographics to share that information and allowing them to make an informed decision about what's best for them, particularly when it comes to potentially invasive tests like a biopsy. So I just wanted to share one more kind of clinical example to show how this can work as well. And now I'm talking about a similar patient with the same symptoms called Martin. Again, non-specific abdominal symptoms. This time his celiac serology blood tests are negative. All his other blood tests are normal, apart from a raised CRP test result. Now, I did my PhD on CRP. It's an interesting test, I think. It's a non-specific test, so it doesn't just relate to one diagnosis, which makes it more complicated, because it's a marker of inflammation, and that can be increased in infections, in autoimmune conditions, but also in certain types of cancer. And what's interesting is we can see when we look at the data on CRP, this is data from my own PhD, and looking at cancer incidence, it really illustrates how blood testing involves a series of Bayesian steps. And actually the first Bayesian step is that actual decision to test in the first place. So you can see in the untested population there, the cancer incidence around 1%. The mere fact that a test is done roughly doubles that risk. So in the tested population, cancer risk is increased. Now, if that test comes back negative, the risk of cancer decreases somewhat, but not back to baseline. So you can see that in those patients with a negative test result, risk of cancer is still around 1.5%. If the test is positive, cancer incidence rises, and if a second test is done and test result is rising further, then the incidence rises still. So you can see how it's a series of Bayesian tests. What this means can sometimes be a bit paradoxical, and I think this is where we can sometimes fall down. So the paradox of the normal test result is the fact that you've had the test result, the test done, increases the cancer risk. That's shown by the green line at the top there. We've stratified it now by gender and by age. The normal test results, the blue line at the bottom, but you can see the red line in the middle is those patients with a normal test result who are still at an increased risk of cancer. You might say these are small risks, we're looking at sort of 2 to 4%, but actually cancer's a bit of a special case, and we're recommended by NICE to be making urgent referrals for anyone with a 3% risk or above. So actually, you know, you can see that if you're male over 70 with a normal inflammatory marker, arguably you should be getting an urgent cancer referral. How can we make this work in practice is challenging, but we need to not be too reassured by a normal test result. And I think a really nice summary of this was made by there's a short TED talk and book that goes with it about the laws of medicine, one of which was that a strong intuition is much more powerful than a weak test. So this is because this kind of heuristics, anchoring and adjustment can be prone to the biases, and there's a tendency to trust the results of an objective test more than one's own subjective clinical judgment. So there's a science, there's maths, and there's also an art to medicine. I think the challenge is kind of pulling these together. So take-home messages. Test, update your chance of having disease. I think we need to work harder in how we communicate that with patients. To understand the test, we don't just need the test results and the test accuracy, we need that pre-test probability. Context matters. We use mental shortcuts to try and do this in clinical practice rather than mathematical formula, although we have to learn those formula in order to calibrate our clinical judgment. But we have to be aware of the cognitive biases that puts us at risk of. And I'm working to try and generate more tools, more training to help clinicians, but also to help us to share this information with patients without, hopefully without over-alarming people. I think it's a really challenging and interesting area to work in, and great to be here. I think that's it. Thank you.
Jess, thank you so much. That really is communicating maths to the public without any maths at all being communicated to them. Are there any questions? I've got lots. Chris.
So it's controversial. So there's an increasing interest in the use of AI in medical diagnosis. So
Yeah.
I'm interested in your views on that.
I think that's probably the future. I don't think it'll replace. I think it's already starting to happen. So I'm already starting to get little pop-ups on my screen, actually, telling me that a patient's got a risk of cancer, and have I thought about the fact that their platelet tests were raised recently. And I think that can be a helpful tool. It helps us to think of diagnoses. And I suspect that that's going to increase. It's dependent on the quality of coding and information in the medical record. And although test results are well coded, the symptoms and all those things that go into generating that pre-test probability aren't always well enough coded at the moment. So I think that's the limitation, perhaps.
Thanks very much, very interesting. Specifically about the celiac disease example you gave, 13.5% probability that you have disease given positive test.
Yeah.
My wife and I went down this journey. She was diagnosed with celiac about 10 years ago. Given that 13.5% number, we always wondered why bother doing the blood test, given that she could switch her symptoms on and off by going on and off gluten. Why not just go straight to the biopsy?
Well, I think we would be doing a heck of a lot of biopsies, because actually most of the time when I do the celiac test, the blood test, it comes back negative, because a lot of the time the challenge in primary care is the symptoms of serious conditions overlap with common less serious conditions. So it's if you like a sort of triage test. It's not a diagnostic test on its own, although if you have very strong symptoms, a family history, and we don't just get a positive or a negative test result, we get an actual number, and that is informative as well. So if you've got a very high number and lots of symptoms, arguably the opposite, perhaps you don't need the biopsy at all. I think it's trying to make that judgment and put all that information together that's the challenging thing.
I'm curious, in medical school, did they teach much about the difference between positive predictive value and specificity? Because I've noticed if you look at like standardized diagnostic protocols, sometimes they'll say, for step X, you have to get a positive test on a test with some assay with specificity greater than 90%. I mean, a D&D rule of a critical hit is a specificity greater than 90% test, right? If you don't specify the sensitivity, it doesn't say anything about positive predictive value. So, do you think this is well understood in the medical community? It's really different between specificity and positive predictive value? Or?
I mean, it's a core part of teaching, but my concern is it's often taught sort of in the early years of the kind of preclinical, and sometimes it's taught by kind of, epidemiologists or experts in test accuracy, but they're not integrated into the clinical teaching as well as I think it needs to be. And I think that's the real challenge, is bringing the theory of medicine into clinical practice, so you don't just sort of learn biology, biochemistry, statistics, and then forget about it when you're doing the clinical practice. I've been doing work with students trying to sort of improve that. COVID's been a great kind of teaching example. There's lots of information and lots of examples where high or low pretest probability aren't always taken into account when interpreting the test result.
Yeah, I think you got a couple of really good lessons in your communication there. First of all, you didn't use the term false positive rate,
Yeah,
which
I
is
hate that one.
hopelessly ambiguous, and you can see the mess that people got in using that term throughout the whole of COVID.
Yeah.
And the other thing you put over very well, that risk is not an objective quantity. It's a subjective judgment on the basis of the knowledge you have.
Yeah.
Which I think is that's really good to have it in there as a good basic. Are there any further questions for Jess? Oh yes, great.
I just wondered if you're saying it's great to have an informed conversation with patients, right? Your PhD research that you showed says that you've taken these patients, you've tested them, they've tested negative, now they've got a higher chance, right? How do you have those conversations while being careful not to give people the impression that the testing has increased their risk, you know, causally.
Well, we call it safety netting, I think is the answer. And I think that although this sort of paradox of the normal test result isn't always well understood, I think most doctors have got the idea that normal tests don't just... I think patients sometimes get the perception that they've been tested, so everything's been ruled out. Whereas I think doctors are pretty... They understand that rule that I said, the intuition can be more powerful than the test result. And so what we try and do is say, okay, well, the tests are clear at the moment, things are looking okay, but if you have ongoing symptoms, concerns, if you have this, or this, please come back. I'd expect it to be settling down over the next week or two. And that's kind of core part of general practice, is actually the test of time. And, if it is one of the majority of self-limiting conditions, everything will settle down. If it's a patient with something more serious, then they will come back. Or you might even put in place, if I had someone like Martin, I'm really worried about him and his test result was negative, I might arrange a follow-up, routine follow-up to make sure things have settled down.
Can I ask one final? Are you teaching medical students?
Yes, mostly research, but I do teaching as well.
You're showing the expected frequency trees
and in fact,
and all
this
that
weekend
stuff.
I'm also doing some teaching with I think they're year 8 school students.
Yeah,
I think it's really interesting to get it right down to that
Excellent.
level to try and talk to them about this sort of stuff.
Very good.
So,
Thank you very much, Jess.
Thank you.
Great.